Okay, well, once again, welcome to the Public Health Services and Systems Research in Progress webinar series for Wednesday, September 10th. We're excited about today's seminar and glad to see so many friends and colleagues logged in and joining us for this webinar. I'm your host for today. This is Glenn Mays. I'm a professor of health services research here at the University of Kentucky in the College of Public Health, and I direct the National Coordinating Center for Public Health Services and Systems Research, which is bringing you this webinar series today with the support of the Robert Wood Johnson Foundation. Let me start by just telling you a little bit about this Research in Progress webinar series. For many of you are familiar with the our coordinating center and the Public Health Services and Systems Research initiative that is funded by the Robert Wood Johnson Foundation. Through this national program, the foundation supports a variety of researchers and research networks that are all focused on conducting applied research to help us uncover better ways of organizing and financing and implementing public health programs and services, and help us learn more about the health and the economic impact of public health delivery across the U.S. Through the work of the foundation and the work of our coordinating center, we have developed and supported more than 100 of these kinds of studies over time through this initiative. So we have a large and growing cohort of applied research studies focused on public health systems and public health services delivery. We've launched this webinar series to provide a forum for research investigators and their partners to share findings and preliminary findings and knowledge generation that occurs really at any stage of the research and implementation process. We encourage investigators to participate in this webinar series and to share again their progress with the implementation of their studies and with the knowledge that their knowledge and their preliminary findings are likely to be a benefit not just to their research team but to this larger cast of characters who are traveling with us in the field of PHSSR. And that's really the purpose of this webinar series, to provide that venue for learning from research in progress in this field. Before I introduce our speakers for today's session, just a quick recap that you see on this slide. This shows you some of our past presenters at the Research in Progress series here. We have been showcasing for the last several months investigators who've been funded under our pre- and postdoctoral research award program in PHSSR, which is a very important pipeline building program that we direct, again, with the support of the Robert Johnson Foundation that is supporting dissertation research as well as early career postdoctoral research from new and up-and-coming investigators in the PHSSR field. As you can see here, we've had some great sessions already earlier this spring and summer, and we're going to continue that today with another one of our investigators that are funded under this pre- and postdoctoral research award mechanism in PHSSR. So without further ado, let me introduce our speaker, who you see featured here on this slide, Britney Johnson, who is certainly no stranger to the PHSSR research crowd, and in particular no stranger to our practice-based research networks. And she's been an important driver of work in the New York PBRN. But Britney is a program research specialist with the New York State Department of Health in their AIDS Institute, and has done a lot of work looking at public health program organization, financing, delivery, and in particular economic issues and cost effectiveness issues around delivery, with a special focus on HIV and STD prevention and control programs. As I mentioned, she's been a very important player in the New York public health practice-based research network, one of our one of our leading PBRNs in our PBRN program that's part of the PHSSR coordinating center here. And I feel bad because Britney actually, because she's plugged into our PBRN work and plugged into so much of the work that we're doing across the sphere, her work has been gets featured a lot in the various research, dissemination, and translation activities that we conduct through the center. So thank you again, Britney, for being with us in this venue and being willing to provide another lens on the work that you're doing in HIV and STD prevention and control in New York with your PBRN colleagues. So Britney will be describing her work today. We're also joined with several of her colleagues who will be offering some commentary after and reflections on this work after Britney finishes with her formal remarks. We will have ample time for questions, comments, and discussions from the rest of our participants here on this webinar. So please make sure to note your questions. We're going to have ample time for discussion after we hear from Britney and her colleagues. And also, as a quick reminder, please make sure to mute your phone line so that we've got a good clear audio portion for this event. If you're joining in and also dialed into the video portion of the content over the web, make sure that you've got your computer speakers muted so you're not getting feedback and that's not being generated here. So with that, let me turn the virtual stage over to Britney.
Thank you for that introduction, Glenn, and thanks to Ann Kelly and all the staff at the Coordinating Center who, work tirelessly to kind of put together these sorts of dissemination opportunities for all the projects and grantees that they fund. Today I'll be presenting on a research project and evaluation that was conducted as part of the Pre- and Postdoctoral Research Award, but was also very tied into some of the other research projects that the New York State Practice-Based Research Network has been involved with over the past few years. First off, for those of you unfamiliar, although as Glenn said, we've presented a lot on this research already, we're looking at partner services in particular in New York State, and shown is the definition of partner services. So what are we researching question? This is the current CDC definition and terminology for partner services, but the act of contract tracing or partner notification has been around since the early 1940s when health professionals were using it to manage the syphilis epidemic. This is really boots on the ground public health work. These are staff who are disease investigators. They're out in the field conducting case interviews, tracking down partners, working to make sure that people who may have been exposed to HIV or STDs get tested and treated if they're found positive. And partner service has been shown to be a really effective way of identifying new and undiagnosed infections. The CDC recommends this for all newly diagnosed cases of HIV and syphilis, and is also encouraged for gonorrhea and chlamydia as health department resources permit. So knowing what partner services is, I'd like to give a little bit of context as to why we're studying it and why this is an important research topic. Historically, services for HIV and STDs have been separate, despite often serving similar populations who have overlapping risk factors. If you're contracting an STD, odds are that you're engaging in the sort of risk behavior that might put you at risk for contracting HIV. But as I'm sure anybody who works in public health knows, siloed services and programs and data and funding streams have long been a problem that we're trying to overcome, particularly in PHSSR. Part of an attempt to resolve that, and the CDC has spent the past several years trying to combine and streamline their guidelines and priorities, starting back in 2008 with integrated partner services recommendations. And so this is the first time that there was any consistent messaging and guidance for conducting partner services for HIV and STD, which helped resolve a fair amount of inconsistency between the older separate guidelines for these services. In addition to that, the CDC's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention released a white paper in 2009 on Program Collaboration and Service Integration, or PICSI for short. And PICSI was really focused on blending these interrelated health issues, activities, and strategies to do this comprehensive delivery of services, particularly on the front line and on the ground, and encourage health agencies to combine their resources for those clients. And more recently, in 2011, the CDC has announced its high-impact HIV prevention strategy, which focuses on using these combinations of, proven, effective, and scalable interventions to try and address the HIV epidemic. And I'm mentioning it here because partner services is one of those critical high-impact interventions the CDC emphasizes. So in response, going back to that PICSI recommendation in 2009, the New York State Department of Health merged its field services programs for HIV testing, counseling and testing, and STD partner services into one HIV-STD field services program. The goal there was to train the staff, provide integrated services at that front line for anybody who's diagnosed with infection. The New York State PBRN got involved in 2011 with a research implementation award to really evaluate the integration process and identify some of the quality measures related to the delivery of those integrated services. So where are we looking at this? Where are we studying it? We focused on the integration of HIV and STD partner services staff in 5 regional offices serving 45 counties in New York State. So these are state-level staff who are conducting these investigations for counties who don't receive funding to do partner services on their own. And so the area covered by these staff accounts for about 1/4 of the cases that are diagnosed of disease morbidity in New York State. So we did a lot of different projects. I don't want to, stay too long on our past research. We did surveys and focus groups and provider surveys, but I really want to focus on our attempts to measure the outcomes of integrated partner services work, since that was part of, the goals of PICSI were to improve service delivery. So with these integrated staff who have more training, are we able to reach more people? As far as partner services go, were we able to conduct more interviews or find more undiagnosed cases? What did this look like on the other end after we did all this training? And what we found really is we encountered a lot of challenges trying to measure the outcomes of these programs and of the integrated programs. Most of the measurement of partner services work was really focused on collecting surveillance data, but didn't really have a lot of information on the case process. While staff were cross-trained to deliver integrated services, the data systems were still separate. So looking at things like interview rates or case assignments, we couldn't do with any degree of consistency because each of those systems had different definitions for those. For HIV, it was really difficult to discern between partners who may have been elicited from a medical provider versus the work that was being done by our cross-trained staff. And in addition, there was significant time lags in trying to access this data. It took somewhere between 6 and 12 months to really get program outcomes because most of these systems were still paper-based where workers were filling them out, mailing them in, and having them data entered somewhere else. So when it really came to managing the program, there was a lack of timely and reliable data to work with, and it limited our ability in that project to really measure the performance and outcomes of the program. So in response, in conjunction with the PBRN, staff at the State Department of Health and the AIDS Institute worked on developing a program management application to start collecting this sort of data. We looked at quality and process measures that weren't available or easily captured through the surveillance systems, and then designed an application that really was focused on the work and the performance of staff in these programs. The system was developed really collaboratively. We took input from field supervisors and frontline staff and those who would be doing data entry to make sure we were designing a system that was useful for all the people who would be, utilizing it. It took about a year to design that program management application and then another 6 months to roll it out and train staff. So since its launch, there's been a lot of benefits, by giving program managers at those regional offices local control of their data. They've been better able to assign cases to track their workload. By combining HIV and STD partner services work into one system, we're able to actually look at similar measures across infections and then track that performance more reliably. With that real-time access, managers are able to manage cases, assign cases easier, provide real-time responses to queries about, overall caseloads or infections or the work that their staff are doing. And, because this is looking at the process, it's really complementing the surveillance data systems that are focusing on those outcomes. But of course, now that we get a shiny new data set to work with and it's growing and growing, we obviously want to make good use of it from a research perspective. So the follow-up research that I was awarded that pre- and postdoctoral researcher award, formerly the Junior Investigator Award, to use this PMA, this program management system, to evaluate partner services performance. And so again, this is that emphasis on the process measures versus the end game, the outcome measures. And for the purposes of this presentation, now that I can get into the meat of it, I'm going to focus on a few key questions that really looked at the beginning steps of partner services work, namely the interview and partner elicitation process. Particularly, is there a difference between the interview rates for HIV, syphilis, gonorrhea, and chlamydia? We've never really been able to determine that before because of those separate data systems. Is there a difference in the timeliness of interviewed cases across diseases? So how quickly do we get to these people, and what's our likelihood of interviewing them in a timely manner? How many partners are elicited per interviewed case, and how does this vary? There's a lot of anecdotal data about this, but we really didn't have any concrete data that compared this across different types of infections. And then does the interview method impact the number of partners elicited? Whether you're interviewing somebody in the field or in a clinic, are they more likely to give you information that you need to follow up with notification than if you're talking to them on the phone? With resource constraints, there's a lot of push to do more office work or desk work, but how does that impact the outcomes that we might be aiming for with this sort of program? I'm showing the CDC flowchart here. You don't have to look at the details there. As Ann said, the full version of that is attached on the upper right-hand corner. But this is just, if you think partner services is a simple process, it's very, very lengthy, and there's a lot of steps and a lot of opportunities for attrition. I'm talking about for this project, the dotted line on the top of that flowchart from the index interview, those beginning steps of the case process, which really have a lot of impact on the bottom of that flowchart, which is the case outcomes, getting these partners who may have been undiagnosed, tested, and if they test positive, getting them treated. So the methods for my analysis was to look at all closed cases in the program management application for 2013. They were stratified by the disease, by the regional office that conducted the investigation, by the interview status, whether they're interviewed or not, when they were interviewed, and the method that they were interviewed. And so for those that were interviewed, we looked at the partner elicitation rates from those cases. To keep this a very kind of clean project, I got rid of any of the duplicate cases, dual diagnoses, or non-matched partners who may have been worked but called in from another jurisdiction. So the real focus here is to look at these index partner pairs to see how that impacts case outcomes. All this information was pulled from an Access database, imported into SAS for cleaning and analysis. So we ended up with about just shy of 11,000 records altogether, 5,518 index cases, and about 5,300 partners. And as you can see there by the pie charts, the vast majority of these cases, over 90%, were actually for chlamydia and gonorrhea. So despite being a lower priority infection per CDC recommendations, they really make up the majority of casework here. And then in the analysis, we did some chi-square analyses to look at whether there were any statistically significant differences related to those research questions. So I want to walk you through the outcomes table here. Let's see if I can get the little pointer here. Oh, fancy little arrow. Does that pull around? Can you guys see that?
Brittany, I think you have to hold it and drag it.
Drag it, let's see. Oh, it doesn't look like it. Yeah, so maybe I can just draw here. But so I'll just start from the beginning there. Is there a difference between the interview rates for HIV and syphilis and other infections? So we look at the overall assignments. Those are those pie charts on the top line for cases assigned. And then now we can look at the interview rates for those cases. Oh, well, somewhat. I'm just going to draw all over that. That wouldn't be a good idea. The interview rates are very different for HIV and other STDs. You can see that of those cases assigned, only 55% of HIV cases were successfully interviewed by our staff, while over 85% of the early syphilis cases were interviewed. So there is definitely a significant difference across infections on the successful interviews that come out of those initial assignments. And you can see that chlamydia and gonorrhea perform pretty similarly. Between 65 and 75% of those cases are getting interviewed. Question 2, is there a difference in the timeliness of these interview cases? Yes, and it's significant. When you look, we can see that combining this, over 88% of early syphilis cases were interviewed within a week, while only about just shy of a little over 40% of HIV cases were interviewed within a week's time period. 58% of those cases were interviewed more than 7 days after they were initially assigned. And that's not even the day that they were diagnosed, but when they were assigned. And does the interview method differ? And we do see that there's a significant difference in how these cases are interviewed. And that's actually something we'd expect to see. At a majority of HIV and syphilis cases are interviewed in the field, which is something we want to have happen, while for lower priority infections like gonorrhea and chlamydia, the majority of these case interviews are being done over the phone. Partner elicitation rates, do they differ? Yes, they do, and the number of partners differ significantly. As you can see, this is looking at, for every interviewed case, how many partners are named or offered up for us to follow up on. And while it's less than 1 for cases of HIV, gonorrhea, and chlamydia, syphilis is over 2 partners per interview conducted. And we see that, again, the distribution of the types of partners, and as you can see, there's 46% of early syphilis cases that are interviewed are offering up multiple partners for the health department to follow up on. However, for HIV, 56% of those cases that are interviewed don't give any partner information. And so then looking within each infection that's being assigned, is there a difference? Does the interview method impact the number of partners elicited within each type of infection? And the answer is yes, and that's significant across any type of PS case assignment. You're more likely to get partners via in-person interviews, say through the field or the clinic, than over the phone, and that's a pretty consistent finding. And it kind of goes along with the common sense that you would think if you're sitting down face-to-face with a person, they're more likely to give that information to you than to talking to what might be pretty much a stranger on the phone and revealing that information. But we do see, for HIV, 78% of attempts to interview an HIV case over the phone don't give out any partners for notification. So that should really, tell us that it's a last priority, really. They won't speak to you in any other way, try and talk to them on the phone, but there's much bigger likelihood of success at interviewing them in person. And the same thing is consistent with syphilis. Half of syphilis cases interviewed over the phone do not give any partners, where we see that in person the outcomes are much better. And so I'd like to talk about how this kind of ties into the adherence to the New York State tasks and standards. So for partner services, there are standards that are put out and what we expect or we hope these programs to be performing at, but we've never really been able to look at them and compare them consistently. And when we do see this, we look at these standards for all of these infections, including HIV. We see that these standards are being met for chlamydia and gonorrhea, somewhat being met for syphilis. We're not interviewing as many as we'd like, but at least the turnaround for those cases that are being assigned is very quick. But for HIV, we're not meeting either of the standards associated with getting to this patient in a timely manner. And with a goal of interviewing all cases, and we've only interviewed 55%, it's a pretty big difference that we should be, further investigating to try and understand why we might not be meeting those outcomes and standards, or reevaluating the standards to see whether they're really feasible. So just the discussion of those findings. So based on caseload, staffing researchers are really overwhelmingly dedicated to gonorrhea and chlamydia. That's the majority of the day-to-day work that these partner services staff are conducting, and we see that those outcomes are actually pretty consistently good and meeting our expectations. But across nearly all the other measures evaluated, HIV case investigations had worse outcomes than those for syphilis and other STDs. HIV cases were significantly less likely to be interviewed, and if they were interviewed, it was significantly less likely to be in a timely manner or to yield any partners for potential notification. And so despite having tasks and standards for HIV, after 4 years of integrated partner services, they're still not being met. The implications of this kind of stuff, this is an evaluation of a program at one point in time. An evaluation is really only the first step for this. We know more about how these programs are performing and the differences here, but we don't really know why there are such significant differences between HIV and STD outcomes. Quality improvement efforts should really focus on identifying the underlying causes of this partner services underperformance. Could be issues related to the training of these staff. Since they don't conduct HIV PS all that often, are there issues that they might not be, or are the people who are diagnosed with infection dealing with other mental health or substance abuse issues or different age groups or priorities that these staff might not be prepared to address or when they're doing this partner services work. Do we need updated or integrated manuals and field resources? While the CDC has integrated guidelines, the state still has slightly inconsistent or different guidelines that don't really reflect the integrated work that we're encouraging staff to be conducting. There could be issues with collaboration and communication with HIV providers. HIV is an STD with a lot more stigma behind it than a lot of other curable infections, and providers often have a strong desire to keep the confidentiality of their patients high. The messages that your medical provider is telling you about the health department, the timeliness of those HIV providers reaching out to us to be there when test results are delivered, or when the client is going to be in the office. How do those relationships impact the partner services performance of these staff? And there are also, you also have to consider the differences in lab reporting. While we have in New York State automated lab reporting systems, HIV requires multiple layers of confirmatory testing. So by the time this case would actually get assigned out to a health department staff member, it could be as long as a month from when that individual initially got their reactive results. So they may have already processed all of this, information related to their diagnosis and not be interested in talking to the health department. So how does that impact the timeliness and turnaround from, diagnosis date to when our staff are actually trying to do outreach to these patients? Obviously, as with any, data analysis, there are plenty of limitations here. This PMA was only in place for 4 months before the sampling period that I presented, so there might still be a learning curve and data entry issues that may have influenced the outcomes. This is only including the partner services conducted by the regional offices. It does not yet extend to local health departments who are handling a lot of the statewide morbidity. So we don't know yet whether these outcomes are comparable to what local health departments are doing. It doesn't reflect regional variation in case outcomes. I did present at Keeneland on some of the regional variation. Within those offices, we see some pretty big differences, although those overall trends that I presented here still remain consistent. Confidentiality issues limit the ability to really look at these outcomes by patient characteristics, so to really see maybe there's a relationship between the patients and the partner services outcomes, and we're hoping to do that as we start matching this with some of the surveillance data, but we're not there yet. And obviously doesn't include the outcomes of the partner notification, so that's where we have research ongoing to look at those further downstream steps of the case investigation process. So with that, I'll just thank Jim Tesoriero, Mara San Antonio Gaddy, and April Richardson Moore, who head up the Partner Services Field Services Program and have so graciously let me poke around in their data and work with their staff for several years now, and Sylvia Pirani, who served as my mentor on this project, and of course also Robert Wood Johnson and the Coordinating Center for funding this and offering these dissemination opportunities. But I'll leave it with a quote from my favorite quality guru, W. Edwards Deming. Can't describe what you're doing as a process and you don't know what you're doing. And that's all. Thank you very much.
Fantastic. Thank you so much, Brittany. This is very, very, very interesting and thought-provoking work. We're going to hear from a couple of colleagues of Brittany's to offer their kind of reactions and commentaries about this work, and then we'll open it up for general questions and discussion from the audience. And so I think we'll first invite Sylvia Pirani to make a few observations and reactions. Sylvia also is well known to those of you who are part of our public health PBRN program, again as a leader within the New York State Public Health PBRN. Sylvia directs the Office of Public Health Practice in the New York State Department of Health, which provides technical, administrative, and fiscal and data and analytics support to the state health department's programs and also the 58 local health departments around the state of New York. As I mentioned, she's been a driving force behind the New York State PBRN and the great work that it's done, some of which we've seen showcased today. So, Sylvia, would you like to make some observations?
I would. Thank you very much, Glenn, and thank you for organizing this opportunity to talk about our work. The New York State Public Health Practice-Based Research Network was established in 2010 with funding from the Robert Wood Johnson Foundation and through the support of the National Coordinating Center. Our purpose is to conduct public health services and systems research that can improve the practice of public health agencies. That is our goal. And we have key principles which are similar to others, I think, other PBRNs, strengthening the collaboration between practitioners and researchers, and also ensuring that the research benefits the practice community. As our first study was in partnership with the New York Academy of Medicine and the New York State University at Albany to describe the decision-making processes in local health departments and addressing community health priorities and identifying what facilitated their use of or what prevented them from using evidence-based decision-making. And then our second and third studies were related to the work that Britney described today. The first one was that Research Implementation Award to assess the impact of integrating the delivery of partner services for HIV and STDs, and then the DAC study looking at partner services from an economic perspective. And we've also had the benefit of getting one Quick Strike Award, which is completed, and another one which we were just received last week. So to help us assess our state health improvement plan, the prevention agenda. So we're very excited about this. So I wanted to make a couple points about being a PBRN and participating in this effort and why it's so important. So despite our goals for being a research-based agency and our strong relationship with the State University at Albany School of Public Health, which we helped establish here, it's a big challenge to get policymakers and funders to invest in the time and the resources to do public health services research. With budget cutbacks, with retirements, with the push to keep doing the same amount of work or more work with less staff, it becomes really challenging to fit this into our everyday routine. So the ability to get this grant from the PBRN and to make it part of our work is essential, especially when it's tied to a quality improvement effort, as Britney talked about. That's exactly what we need to be doing during these budget cutting times, is figuring out whether what we're doing is effective and then translating that knowledge and research into the field so we can improve our practices. We have a lot of quality improvement in this agency, sort of in a up until recently more of a haphazard way with the goal of accreditation. We've incorporated it more and are trying to become a public health agency that incorporates it throughout the system, so this is a good example of that effort. The other comment I wanted to make was about the challenges of growing the public health workforce and making sure that workforce understands the importance of doing practice-based research and learning from the results. And so, you know, we grow the workforce one person at a time. So this PBRN was essential in helping us bring Britney Johnson here as a student first during her career, and then having her now, you know, shown her tremendous skill and ability and making her part of the AIDS Institute, where I think she's been, you know, been able to keep a hand in both places, both doing the research and in helping improve the program. So that's also been an essential benefit. So those are the comments I wanted to make.
Fantastic. Thank you so much, Sylvia. I think that's a very important perspective to hear from in terms of how this kind of work gets done, how it gets embedded in the real world of public health practice and public health agencies. And again, some of the benefits of generating this kind of synergy between the worlds of practice and research. We're also joined by another colleague, Dr. James Tesorero, who is director of the AIDS Institutes, their division of HIV, STD, and HCV prevention within the New York State Department of Health. He has a long and in-depth history and career of working in HIV prevention and control programming and applied research. He's also chair of New York State's the Department of Health's Internal Review Board, which, as we all know, is a very important entity for conducting research, and in particular practice-based research within public health settings. And so we invite Dr. Tesoriero to also make some observations and reactions and comments about this work.
Thank you, Glenn. I'm happy to be here, and I'm happy to have the opportunity to share the impact that this work is having, and it's already had, on how we do business in New York State specific to HIV prevention programming. So we have a complex division. I mean, of all the things that we do, of all the programs that we implement, and it's much more than HIV. It's drug user health, it's opiate overdose prevention, it's LGBT, which is lesbian, gay, bisexual, transgendered health and awareness, it's sexual health and awareness campaigns. Of all the work that we do, and of our entire $70 million+ portfolio, I would say that without a doubt, this DIS work, this field services work, is the most complex of any of it for a number of reasons. It has to do with the geographic distribution of the entire state, the fact that we have field services staff that work directly for us doing this work, and the fact that we have to do it through county contracts as well. It has to do with the fact that we have a data system that we really don't control. So much of the work is dependent on a data system that is not housed in my division. It's not housed in the AIDS Institute. It's housed in the Department of Health in general, and we have limited ability to affect change to that data system, and so it really wasn't meeting our needs. So for all those reasons, and then of course the nature of the work itself, the fact that there's 4 diseases that we focus on, and that the nature of the work associated with surveilling those diseases is so very different. For all those reasons, this is incredibly complex. So when I took this job 4 years ago, I was a researcher. Initially, I thought it wouldn't be, I looked at our portfolio and I said, well, this is something that we should be able to get a handle on. It's fairly simple. Somebody's newly diagnosed with a disease, you go out, you find them, you inform them, you get partners, and then you test them. And on paper, I guess it is, but in practice, this has been the most complex of anything we've had to try to do. So all that to say that this research is invaluable to us. I'll just mention 3 or 4 quick impacts that this research is already having. One is Brittany's already covered, and that was we learned early on, or realized early on, as we really understood the complexities of the data system that generates the case assignments, that we couldn't do consistent, good, continuous quality improvement work with that data system. And so we did create a performance management application that has been very helpful to us, and it allowed us to actually produce the data that you've seen in part today. And so that was one immediate impact that this research has had, is for us to create that system. Subsequently, we've learned that even that system, in the course of evaluating that system, we realized that we have limitations in the data quality associated with that, and it really has to do with the way that we enter data. And so another impact that this research has had, or is having, is that we've realized that we really can't have our disease investigative specialists, our field staff workers, be responsible for data entry, because it's just not something they're good at, and it's not consistent with their job functions. And so we've freed up resources to hire data clerks to do that. And so that's a very real impact that we didn't realize until we actually had gone through all of this work and had done some of the quality checks to it. So those are very 2 tangible impacts. Another impact is that we have realized that we needed to institute a formalized continuous quality improvement approach to this work. Brittany had mentioned some of that as recommendations, and we've taken those recommendations, and we're actually in the process of implementing them now. And so that work will involve standardizing and sort of linking up the contracts that we have with our county health departments with the work that our field services staff do. They really weren't 100% in sync. And so making sure that those outcomes and those objectives and all the indicators that go into them, and just the nature of how we do business, is now more synced up between those 2 initiatives, will be part of the CQI process. Regular data review is part of that as well, as is corrective action plans and corrective action planning when things aren't going right. So the ability to really act on the fly. And of course, regular access to data is something that we still have to overcome. We have it figured out with the work that we do directly, but we have to figure out a way in the months to get this information for our entire state, not just for the workers that work directly for us. So those are all impacts that this work is having. Another impact is probably substantive impact, is that we realized that in 2010, on paper, the integration notion, Pixie, and all that stuff that Brittany mentioned makes sense, and it's certainly good conceptually and easy to understand. But as it rolled out, what we've realized is that cross-training every field service staff worker to do all 4 disease investigations probably isn't the way to go, because HIV and syphilis are fairly rare occurrences, and so there's not enough of that work to really go around. And so we really need to, I think, to make HIV work, we're really going to have to improve the outcomes around HIV, we're going to have people specialize in doing HIV and syphilis work, because those 2 diseases, the individuals who contract those diseases look very similar. The nature of the work looks very similar, and so I think what we're going to be doing is moving away from complete, integration into some form of specialization for the diseases that are more rare. That'll help to some extent, we think, and then the other impact is really investigating why it is we're getting so very different outcomes for HIV versus syphilis, when again the populations are the same and the nature of the work is fairly similar. So that will be built into our continuous quality improvement process as well, and that'll be an active discussion that we're going to have with our county health departments that we fund and with our regional staff. So all that's beginning probably October 1st. And then the only other thing I want to say before I turn it over to questions is that I think indirectly this project has also helped us really expand our scope. We felt confident as we learned more about how the work is being done to really expand the nature and scope of the work. And so we've added something called our expanded partner services work here, pilot here, which is doing work on not just new cases. Everything that you've seen today is on new cases. As new cases are reported, they're surveilled, investigated, and so on. But we've begun, it's almost been a year now, doing work with people who are HIV positive and they've been lost to follow-up. So we use data now to identify people who were positive and not in care. We use those surveillance data then to have DIS staff go out, find individuals, and try to re-engage them in care. And we're having success with that. So all of those things are really the result, either directly or indirectly, of this work. And so we can't be more happy with it. We can't be more happy with the funding for it. And I'll just stop there.
Thank you so much, James. Those are very enlightening comments and reactions, and I'm sure have stimulated some other thinking and questions on the part of the audience here. So we are at the question and commentary portion of our Research in Progress webinar today. So we invite you to articulate questions and comments. The best way to do it, given that we've got a large number of folks with us today, if you are joining us through the online portion here and you have access to the chat box there, it's on the lower right-hand side of your screen. If you could type your questions in there, that'll help us manage the question flow. Some of you may be on the audio portion only, and so you can't do that. If you're on the phone only, we'll give you a chance here in just a minute to voice yourself and articulate a question as well. So please go ahead and use the chat box for those who have access to that to type in your questions. To get us started, I might offer a couple of thoughts on this work as well. Again, this is I think very important work, and I think very nicely illustrates the power of the PHSSR applied research study that it can bring to insight about public health practice. In particular, I come to this field from the field of health services research, where we really do use a lens of learning from variation. First, detecting variation in an important element of practice, and then exploring the nature and extent and the incidence of that variation, and then beginning to explore the causes and consequences of that variation, ultimately so that we can parse up and identify what portion of that variation is desirable and appropriate because it represents a targeted or tailored response to a problem or a condition, versus what segment of that variation is unwarranted and therefore represents harmful or inequitable or wasteful variation in practice. And I think this study is pursuing that right down that line of detecting important patterns of variation here, and now beginning and poised well to begin to explore causes and consequences of that variation. In particular, as James noted, some of that the pattern of variation being seen here relates directly to this potential trade-off between the gains, the benefits, and the cost of integration versus specialization when it comes to delivery of high-priority public health services, and understanding where that balance might lie here. There's obviously a lot of enthusiasm and optimism about potential benefits from integrating services in a variety of domains of activity with public health within public health, and the HIV, STD prevention and control domain is just one area where we're seeing a lot of experimentation and have over the last in recent years with testing different models of integration. Can we realize efficiencies? Can we realize improvements in quality or reach through that? And here, in part, we're seeing perhaps some of the limitations of doing that. Economists will note that there are potential synergies to be realized through integration, but also potential downsides, crowd out. As you integrate activities that are all drawing on a common resource, one activity may crowd out the ability and capacity to perform the other, and that may be partly what you're seeing here in looking at the differential performance of partner services activities across the different types of cases. There's also potential for congestion, another term from economic analysis that we use commonly. That as you integrate, you generate bottlenecks, or you surface bottlenecks in the system that can cause congestion, slow throughput, slow timeliness of conducting activities as activities get in the way of each other in terms of the production process. And so that also strikes me in listening here that there may be some congestion that's at the root of some of these patterns of variation that we see here. So obviously there's, as with any good study, you've raised more questions than you've answered with this effort, but as both Sylvia and James mentioned, that just tees up some very nice opportunities for quality improvement processes now to drill further down into root causes of these variations, again, to help us parse out warranted versus unwarranted variation in those measures of performance, and looking for opportunities for addressing them. So I guess I might ask Britney and any of the other commentaries whether you can share any more of your specific thoughts or plans you may have about how you might go forward from here in further exploring what's generating the variation in the performance and the outcomes that you've seen here across the different types of cases, and how do you foresee moving forward to drill down to understanding what's at the root cause of that variation?
Well, I mean, for starters, we're definitely trying to get into that variation with our DAC study. We have a time study in the field right now. These disease investigators have been really good sports about all the research we're doing on them. But we've got the time study to actually look at the differences between these cases and see, what impacts these outcomes. Again, how long these cases take from beginning to end, and kind of get into more detail what happens over the life of one of these cases. So we're really excited to look at the findings from that and get some more information on that. In addition to drilling down, Glenn, you mentioned, the good versus bad variation. We know that there's consistent variation between HIV and an STD PS outcomes, but when we've drilled down and looked at it at a regional level, we also see different types of variation there, and whether that might be, we have some positive deviance, regional offices that are doing a lot of work that are achieving really good outcomes, and kind of we're trying to follow up with them, figure out what they're doing right, and trying to disseminate that to regions that might be struggling more, having a more difficult time with these types of cases and investigations. So we're definitely trying to sort that out, and that's part of the quality improvement process. Absolutely, and this data set has been kind of critical to being able to do that and really focus on the workforce that we have control over and that we can try and improve upon.
Programmatically, this is Jim. I think programmatically, a dream of mine would be to end up at the end of this with a best practices document where we could issue to counties, best practices specific to HIV disease notification, syphilis, gonorrhea, chlamydia, because there's so much variation in the way you could do that job. That if we could get to the point where we thought we had consensus, that would be a tremendously useful tool. It does not exist.
Wow, that's a great idea, Jim. And kind of as a harks back to the checklist manifesto kind of perspective that Atul Gawande has brought into other elements of health services research. If you can get to the stage of identifying those best practices and then manualize it, protocol it, and develop checklists and other decision tools that can help people reduce that unwarranted variation, that can be a powerful mechanism for quality and improvement in performance management. So excellent thoughts. I'm not seeing any questions from the chat box. Let's hear if we have any questions from folks who are on the audio portion or want to chime in. You can go ahead and unmute your phones. We'll see if we can hear from you. We may just have a quiet group with us here today. You've obviously this work has given us all a lot of issues to consider in thinking through how some of these same dynamics may be playing out in other domains of public health practice that we're studying, and also how some of the methods, very clever methods and data sources that you've been able to use in this study might have analogs in other areas of practice. And that is another element of your study that I think is quite exemplary and again worth showcasing across the field, is how you've cleverly making use of data and data systems that were designed primarily to support program implementation, support practice, and you're able to use some of those data streams now as a byproduct. They're being generated as a byproduct of running the program to support applied research and as well as tee up quality improvement opportunities. So that's always a plus when you can do that, when you can use data that are generated through practice and make double duty of data systems that are put in place for practice, but also to use those same resources to support this kind of applied research. It's excellent when those streams can be brought together, and you guys have done a great job of doing that too.
And Glenn, I just wanted to chime in. I see that Anne had a question in the chat box there. Have you been able to use this data set to adjust program priorities to reduce disparities in treatment rates for different diseases? And I just wanted to comment that that's absolutely something we are working on doing with this data set right now, particularly for infections like chlamydia, which use up a lot of staff time and resources. We have within this data set the providers that are doing, the diagnosing, where these people are being diagnosed, and the outcomes of those investigations. So we're trying to use it to prioritize providers who might not be using EPT versus those who we can see are using, expedited partner therapy and treating and kind of being proactive on the medical end to find the providers that are doing that really consistently and find the ones that might not be doing that and target them for additional follow-up and provider education and trying to get them on board with, and familiar with the rules and regulations around that in New York State. So we're definitely going to be using this to try and identify areas where we can improve treatment across both public health and on the medical side to make those outcomes, a little bit better, inch them forward.
Fantastic. Wonderful. Well, unless we have any last-minute questions that somebody wants to put on the table, we'll go ahead and wrap up. Again, thank you so much to Britney and Sylvia and Jim for joining us as part of this seminar series. We do want to highlight we've got a full docket of additional research in progress webinars that are on the schedule already. This slide you see here shows some of the upcoming webinars. As I mentioned, our hope and intent is to have the full complement of investigators who are conducting PHSR studies through the coordinating center and through the RWJF portfolio of PHSR work to be a part of this series and to share their work in progress. So we're always glad to hear from you. If you have an interest in being scheduled for an upcoming webinar, you can contact us and let us know. If you don't do that, you're probably going to be hearing from me or one of our other colleagues in the coordinating center to get you on board, because This is an open science movement. We've got to learn from each other and from the great colleagues that we have here. And just as you get resources and support from the foundation and the coordinating center and its pieces of enterprise, you've got to give back. You've got to pay back to that to this field by offering your expertise and your knowledge to the larger community. So let us know if you like to be to be scheduled as part of one of the upcoming webinars, and don't be surprised if you hear from us as we continue to build out the schedule moving into the fall and winter months for the webinar series. So please tune in next time. You can see here September 24th is our next scheduled speaker in the series, and we look forward to hearing from you in subsequent editions of this series. So thanks to everybody for joining us today. Thanks again to our colleagues in New York for leading this session, and we'll see you all soon. We'll stay in touch. Thanks.
Thank you. Bye-bye.